Good evening, my dear students. How are you all? So, how was the exam? Sorry, there's a little delay in the starting of the session, some confusion with the stream key. So, did you realize something? A lot of chunk of questions from ophthalmology, and majority of them were discussed in your LRR series. So, rapid revision with LRR must have really helped you, isn't it? I think around more than 95% of the questions were covered. So, we will be discussing these recall questions one by one. And before I start with the recall, I just realized, let me tell you something. During LRR series, there was some technical issue, and that whole lecture was in two parts, part one and part two. So I was just observing many of you have just seen part one, not followed part two. Be careful. If it is written part one, you have to see the part two because we want to cover the whole course. There can always be some technical issues. It's a part of the game, isn't it? Yeah. So let's start with the recall session and let it be interactive. Let me know what were the questions asked. Okay. Yeah. So this is the first question I got from you all. I think it's absolutely very simple. Yeah, good evening, all of you. So this is very simple. It has been dealt in the class so many times. Cataract seen in blunt trauma. So what is the cataract which is seen in the blunt trauma? We all know it is rosette shaped cataract. Okay? So that was supposed to be answered. See, in the session, in your LRR session, everywhere, this is how we have discussed this rosette shaped cataract. Blunt trauma, from where does it start? Posterior cortex. We also learned this, that it was from posterior cortex. Padha tha? You have option. We have all dealt with all types of cataracts, metabolic. Maybe next time they can ask you in your NEET PG in metabolic, nuclear. So be very clear with this chapter. Cataract is one of the most important topics. Come to the next question. The purpose of this session is only a quick recall. So I will not take much of your time unless and until you all have some question. So yeah, I keep listening to you all that ophthalmology was challenging. Let me tell you it was not. Let's see further. Come to the next question. Shield ulcer. किसको नहीं पता था? दोनों चीज बताई थी ना? What is shield cataract? What is shield ulcer? What is shield ulcer? It is seen in spring catarrh. That is your vernal keratoconjunctivitis. See, it has all been dealt. So shield ulcer, it is happening because of some micro erosions on the cornea and deposition of mucus on it. This is what is called shield ulcer. Right? Okay. And these are what you're looking at here, the quick revision here. So this was your pseudomembrane on the cobblestones, which is called Maxwell-Lewin sign. Yeah. Come to the next question. Thank you, Faisal. God bless you. So next question. Chalo. I think it's again a very simple question. A child with 1.5-year-old child hai, presenting with, maybe the language is a little different. This is what I got. We could take, that is white eye reflex. What do you call white pupillary reflex? Leukocoria. Ultrasound finding intraocular mass with calcification. Very typical of retinoblastoma. Right? And there's a family history of enucleation. So you have to understand that this can definitely be there can be a positive family history. There may not be a positive. दोनों चीजें हो सकती हैं. ठीक है? So I think this was also not a challenge. It was simple, right? And this has again been dealt in your session, in the revision sessions as well, about retinoblastoma. This is your leukocoria. We talked about, yes, flexner intestinal, right? We also talked about, this is the intraocular tumor seen in ultrasound B scan. Okay, so we come to the next question. I don't know what the language of the question was. Somewhere the language is discussed as that the patient or the child has a case of malnutrition, or this is another language I'm getting, deficiency of which vitamin causes night blindness. I think it's absolutely very simple question. We all know we are talking about vitamin A. Xerophthalmia, night blindness and Bitot spot have been dealt in detail in the revision lectures. Isn't it? So ये भी बहुत easy question था. If you all want to discuss anything in between, you can just message me, I'll discuss. Okay, so there was xerosis and follicular hyperkeratosis. Any xerosis, I think you all know this. Any conjunctival xerosis can be of two types. One is epithelial, one is parenchymatous. So parenchymatous matlab all the causes of scarring of conjunctiva, that comes under parenchymatous xerosis. Okay, so just taking this opportunity to share with you the xerosis. If you talk about xerosis, it can be epithelial xerosis. When you say epithelial xerosis, this is what is due to xerophthalmia or vitamin A deficiency, which you call xerophthalmia. Okay? And what is the parenchymatous means? Parenchymatous is all the cicatrizing conditions of the conjunctiva will lead to parenchymatous xerosis. क्या cicatrizing conditions क्या क्या होते हैं? I think you all know trachoma, all types of burn, Steven Johnson syndrome, ये सारे scarring conditions हैं, ठीक है? Okay. Yeah, I'm coming to that question, Ali. I have that question with me. Just have patience. So after this, next question is order of insertion of the muscles. So this is what they had asked you, and we will understand this. We have discussed the extraocular muscles, their actions, what are yoke muscles. I think, and this is more of an anatomy part. So the medial rectus, wherever it is inserted, this from now we are going to learn it more seriously. That medial rectus is how much millimeters away from the limbus? 5.5. Inferior rectus 6.5. Lateral rectus 6.9 and superior rectus 7.7. I don't think they will still ask you the measurement. So closest is which one? Of course, medial rectus. And when you join all these points, this is what is called spiral of Dulac. ठीक है, इस सब इंसर्शंस को अगर हम लोग ज्वाइन करते हैं तो जो स्पाइरल बन रही है दैट इज व्हाट इज कॉल्ड स्पाइरल ऑफ ट्यूब. Yes, medicine world, I am coming to that question as well. I try my best to cover everything. Just wait. ठीक है, ये हो गया. So how will you learn this? कैसे कैसे? If you from near to far, this is mother-in-law, है ना? And then S, mother-in-laws. So you can learn in any way, but this has to be known from now. Okay, we come to the next question. Next, NF1, I don't know what is the question. One version I'm getting is what is NF1 is autosomal recessive, dominant, it is autosomal dominant. Another version I'm getting NF1, optic nerve gliomas are associated with. If that is the question, again, it is NF1. So what was the exact question? Okay, so they must, Ali, what was the question exactly? Nearest insertion, wo pooch kya raha tha? Can you just share that with me? So image is fine, but what were they asking exactly? Optic glioma was an option. Then it must be this that in neurofibromatosis type 1, which is the tumor which is common. We have learned it so nicely. I think this was covered in your LRR in quite a detail about optic nerve gliomas and what are the features of NF1. In detail, we have learned this. So just you have to be very thorough with this topic. So near to far, if they have asked you the sequence, I think I have already told. Arvind, mother-in-law, NS, mother-in-laws. Yeah, so it's either way. Patient of NF1, most common tumor. अगर ऐसे भी पूछा है तो I think this is again हम लोग ने बहुत अच्छे से पढ़ा था. It is optic nerve glioma. And another question on optic nerve glioma, which you've learned with me earlier also, is fusiform enlargement of optic nerve. Right? Fusiform enlargement of optic nerve. ठीक है, डॉक्टर लाइट प्रॉक्सिमल टू फार वो कवर हो गया ना इजीली. ठीक है, या पूरा सेरेटा नहीं, इट मस्ट बी फ्रॉम द लिम्बस. इंसर्शन पूरा सेरेटा तो क्या चीज है? मोस्ट पेरिफेरल पार्ट ऑफ द रेटिना, वहां कहां जाएंगे हम? ओके, देन वी टॉक अबाउट नेक्स्ट. I think this was also a question. What is the first line of treatment of glaucoma? So when we talk about open angle or we talk about angle closure, first line we are giving prostaglandin analogs. Just keep this in mind. Okay, sometimes you have to always answer prostaglandin analogs. Sometimes in some patients we can start with brimonidine as well, but you will answer this one. Okay, and I'll take this opportunity to share 2 or 3 tricky questions around it. So for more, when you say what is the drug of choice, our first line of treatment is actually a more sensible question. We are answering prostaglandin analogs. Okay, then they can ask you the drug of choice for angle closure. We are again telling prostaglandin analogs. If they ask you drug of choice for acute congestive glaucoma, I hope you remember I talked in the class, then you have to first decrease the pressure. So what do you give? Mannitol or? Okay, mannitol or acetazolamide. And if they ask you what is the drug of choice to open the angle, how do you open the angle? By constricting the pupil, then your answer becomes pilocarpine. So I think you got the difference here. What did I say? So drug of choice to open the angle, of course, how do you open the angle? It is pilocarpine. But drug of choice of acute congestive, it will be your, what will be answer? I said mannitol or acetazolamide. Otherwise, whenever they ask you the drug of choice for either open angle or angle closure, if they just are not telling you the stage of angle closure, our answer will be prostaglandin. Okay, now I think you all are saying that it was about malignant glaucoma. Again, I have dealt with malignant glaucoma. क्या होता है malignant glaucoma? Aqueous misdirection syndrome, isn't it? So, where the aqueous started being, it is started collecting in the vitreous cavity. What is the first line of treatment in that case? We give atropine, which dilates the ciliary ring, breaks the ciliary lenticular ciliary block. है ना? It's therefore called ciliary block glaucoma. So, agar malignant was in the question, of course our answer will be atropine. Can you tell me after atropine, if it is not working, what else we can do? We can go for NDR laser hyalodotomy, creating holes here so that the aqueous can leak forward. Or lastly, nothing works, we go for pars plana vitrectomy. Okay? So then the answer becomes atropine. Okay, so both were asked. I think I have still answered. Okay. Okay, medicine world, I am just going to come to that question. This question was also given to me in this format in the PrepLadder club. See, first line anti-glaucoma drug. So whatever it is, whenever they are asking a first line anti-glaucoma, we should always answer PG2 alpha agonist. Okay? Okay. I'm taking all the versions. And this is all the anti-glaucoma drug revision was done in your LRR session. Okay? So you should take it very seriously. Then coming to the next question, I got one version here, sudden painful loss of vision in one eye is due to lesion. Painful loss of vision only in one eye. And the second version of the question is, optic neuritis is the diagnosis, defect kahan pe hai? दोनों की आंसर क्या है? Optic nerve, है ना? So we are talking about optic nerve. Again, lesions of visual pathway, very in detail it was discussed in the class, revised so many, I think in every session of mine I discussed this, and this diagram you must be very, very familiar with. Hai na? So, this was the question. In malignant glaucoma ultra plan, okay, in malignant glaucoma what is correct is atropine. ठीक है? Malignant glaucoma में atropine. डॉक्टर लाइट ऑर्थोट्रोपिक का मतलब होता है कि और व्हाट इज ऑर्थोट्रोपिया, व्हाट इज हाइपर, व्हाट इज योर इजोट्रोपिया, बताओ व्हाट इज एक्सोट्रोपिया एंड व्हाट इज ऑर्थो. ऑर्थो मीन्स नो स्क्विंट, है ना. So yes, then here it is optic nerve is the answer. I'll come to that question. Let's not mix up. First we'll talking about this. So यहाँ पे क्या आंसर है? Optic nerve. Very good. Okay, we come to the next one. Yes, just to show you that everything details and detail of optic atrophy again should be very, very seriously dealt with. You have to revise and study. Was this a question? I got this question also. Which anti-glaucoma, which anti-ATT drug is responsible for optic neuritis? Was this also a question? I think it's very easy. This is ethambutol. Any optic neuritis due to the drugs, what do you call it? Toxic amblyopia. It's an old term, but we have to be familiar with it. It is toxic amblyopia. And if you remember, we have learned in the class, ethambutol is one. What is the next drug which can lead to? Chloroquine. You know? Then ethyl alcohol. Of course, tobacco. Let's not forget tobacco. Ethambutol, chloroquine, ethyl alcohol, and methyl alcohol. These two it should be very, very thorough to you. All these drugs can lead to optic neuritis. Right? Okay. So this was the question. Next question. So I have included both the pictures. I don't know which one was asked. Was the margin serrated with a tooth? And was it a tooth end like this? In that case, this is limbs forceps. If it was like this, this is back forceps. So we all know this is mainly used to hold the IOL. Limbs is mainly used to hold the tissues. What we revised, if I just remind you, we had revised about bone punch. We had revised about Calagion clamp that has been asked in your exams, right? So now from now you have to be very, very revised and a lot of study in detail about the different surgical instruments, right? Okay, we then talk about, this is the next question. So in your DCR, which is the bone that you are cutting? खुद सोचो, what are the bones? We can be cutting it. There are two bones here. ये दो बोन के पूछ रहे, अगर एक बोलेगा तो lacrimal ही बोलोगे, but what are the two bones here? So you should be very very clear about the anatomy of the orbit, है ना? अगर यहाँ से सोचो, if you just think with me, you will learn it. So this is the frontal, lesser wing of sphenoid, zygomatic, greater wing of sphenoid. यहाँ पे zygomatic, maxillary, this is the floor, and small palatine that will form the floor. What is forming the medial wall? Maxillary, then lacrimal, then your lamina papracia, that is cribriform plate of ethmoid, and then body of sphenoid. The four bones are making the medial walls. Okay? So the message here is just revise your anatomy and the bones forming the orbit. It's easy. तो आप क्या आंसर करोगे? I think it's very very simple. Where are we giving bone punch से हम कहाँ काट रहे हैं? Where is the lacrimal sac sitting? है ना? So we will answer maxillary and lacrimal. Whenever the option is lacrimal, that is of course the answer. No confusion. Okay, it was an IBQ. Okay? So all the details have been discussed with you all regarding dacryocystitis, regarding the anatomy. I think this is another question that a 72-year-old is and has undergone cataract surgery. ठीक है? Decrease in vision हो रही है उसको after 1 month. So it's a long-standing complication. It's not an immediate acute. It's a late complication. It's a late complication. He's a known case of diabetes. There is honeycomb. Actually, mainly it is flower petal is a more common term. These appearances kahan pe? It is mainly on the way you're talking about fundus fluorescein angiography. So the findings are here. So what is the answer? I think we have dealt this in the revision class also. Any flower petal pattern, this is CME. And common sense, when you're talking about any complication after cataract surgery, which is a late complication with the flower petal pattern, everything is given, every point is given to you that there is no confusion. We have to answer cystoid macular edema. Yes, Ali, I think this is the correct answer. Lacrimal and nasal maxillary. Okay, let's see. We come to the next question. Now, I am getting again different versions of this question, that what is the diagnosis of severe NPDR, or what are the criteria which are not included in the definition of severe NPDR. Either way, whatever is the question, you are supposed to know how do you define severe NPDR. Again, remember, this is already dealt in your class. Okay? क्या पढ़ाया था? What is severe NPDR? You should from now be very very thorough with ETDRS classification of diabetic retinopathy, and what you have to know, what they are trying to ask you is 4:2:1 rule. ठीक है ना? यही पूछ रहा है. So 4:2:1 rule में क्या था? Hemorrhages and microaneurysms, either hemorrhages or microaneurysms in all 4 quadrants. Right? That is one criteria. Or looping and beading. So I've just made the figure between looping and beading of capillaries in 2 quadrants, or IRMA. What is IRMA? Intraretinal microvascular abnormality in 1 quadrant. So you will please study this ETDRS classification as well. Okay, voice problem, Shabal? Abhi dekho, theek hai? I'm changing the position of my mic. I think now it's better. Is it okay now? I'll speak more loudly. Ab theek hai? Yes, very good. So in this question, we have to know what is the definition of severe NPDR. Chalo, next question padhe. So again, this was all in the LRR discussion. We come to, I got this question this way. I've taken it the way I got it. So after cataract surgery, endophthalmitis, what is the treatment? Was this a question? Vishesh, agar accept bhi tha na, ki which is not included the criteria, once you know the 4:2:1 rule, you will be able to answer the question, isn't it? Good. Ab batao ye wala question tha, and everybody knows this is again dealt in your session. Endophthalmitis, what is the treatment? We see the vision of the patient, anything hand movement or less, we will go for pars plana vitrectomy. Otherwise, what is the choice of treatment of patient of endophthalmitis? So you will answer. So it's the most dangerous long-term complication, or it could be immediate, both, है ना, for after cataract surgery. ठीक है? Keep remembering this. And another important thing, treatment बता रही थी, either we go for PPV, past plantar vitrectomy, if the vision is hand movement or less. Better than hand movement, we go for intravitreal antibiotic injections. And I think we have discussed this, which antibiotics you have to give. It is ceftazidime and vancomycin can be given, but gentamicin and amikacin are not given as it is maculotoxic. Okay, Visheshan, the question was most important step for prevention of endophthalmitis. Let me first tell you, this is a previous year questions. Mein se hai, few years back they had asked you this. And tell me what is the most important. Is it pre-op antibiotics? Is it post-op antibiotics? It is per-op antibiotics? खुद सोचो. When you are doing any surgery, if you don't do a part preparation, infection हो ही जाएगा. So what is most important? How do you prepare the eye? We go for povidone iodine. ठीक है? So we always clean the area and the cul-de-sac with povidone iodine, and then only that is one of the most important step to prevent any infection. So if that is the question, then our answer is yes. Yes, if that was the option, then povidone iodine is the answer. आप इस चीज पे ऐसे समझो ना, how if you do any surgery without a part preparation, definitely there has to be infection, isn't it? Prophylaxis of endophthalmitis. Acha, then वही है. So how do you prevent? You have to take all the measures to prevent infection, and this is one of the most important. ठीक है? Okay, we come to the next question then. So this was what you were asking, most common cause of blindness in children. I think again it has been dealt in the class by me. Most common cause of blindness in children में क्या बोलना है? Vitamin A deficiency. Otherwise, if overall they ask you, it is always most common cause of blindness in India, in the world, we will always answer cataract. ठीक है ना? Yeah. Okay. No confusion here. One of you were asking me about this question. ठीक है ना? We can move to the next one. What is? Acha, tell me a few more things. What is the most common cause of blindness in developed countries? India में तो cataract है. ठीक है? If they ask you for the world, it is again cataract. For developed countries, you will answer glaucoma. And second will be ARMD, age-related macular degeneration, if glaucoma is not given in the option. Okay? This has also been asked. Another thing they can ask you, second most common cause of blindness. So if they ask you the second most common cause of blindness in India, then you have to answer refractive errors. Okay? Then we will answer refractive errors. Yes, very good. And which is the most common cause of preventable blindness? Can you answer me this also before I go to the next question? Most common cause of preventable blindness in India? Cataract. You can't prevent, but blindness due to cataract you can prevent, na? So your first answer again should be cataract. And if that is not the option, then next best option is trachoma. Okay? So most common cause of preventable blindness in India. Again, first answer would be cataract and second would be, what did I say? Trachoma. Prevention. समझ नहीं आया क्या चीज? Prevention of what? Can you explain the question, ultraclan? Okay, then was there any question on KPs? And if there was, I think it should have definitely not been difficult at all. KPs are the hallmark feature of anti-eye uveitis. You can find few KPs in intermediate as well. It all depends आपका question की framing क्या थी and what were the options, है ना? So this all KPs and all these regarding the intermediate uveitis has been in details have been dealt with. He's telling about Ali, कौन सा last question you are saying? Most common cause of blindness in children. हाँ. So iridocyclitis. It will depend. What was the language of the question? Was they asking KPs are characteristic of, or KPs are hallmark, and iridocyclitis में तो KPs are the hallmark feature of iridocyclitis. Yes, if they had asked you stellate KPs, that is only specific for huge heterochromic cyclitis. ठीक है. या सो एक्वेस फ्लेयर एक्वेस सेल्स पढ़ाया था ना. सो एक्वेस सेल्स क्या है? इन्फ्लेमेटरी सेल्स इन द एक्वेस ह्यूमर. What did we learn? What was the question related to it? It is a sign of active inflammation. And what about aqueous flare? Aqueous flare is nothing but that Tyndall effect, the haziness in the aqueous humor. It is due to the leakage of proteins. Okay? I am again repeating, if it was a fused heterochromic cyclitis as the question, our answer is usme stellate KPs milte hain. Yes, Vishesh, if this was given, then your answer has to be fused heterochromic cyclitis. Yes, Nihal, I came to know about Finchem's test also was asked. So do you all remember what did we learn in Finchem's test? If the patient is looking at the colored halos, what are the three main causes of colored halos? Either it can be cataract, or it can be acute congestive glaucoma, or it can be mucopurulent conjunctivitis. See, if you have been listening carefully, I was very specific about which conjunctivitis and which glaucoma. That is very, very important. Okay, so what was Finchem's test? You pass a stenopic slit in front of the patient's eye. ठीक है, उसको halos दिख रहे हैं, मैंने आपने slit pass की. If that halos break, what is that? It is immature cataract. We are talking about cataract. ठीक है, because some areas are clear, some areas are opaque, the halos can break. But in acute congestive glaucoma, these halos are due to corneal edema and it is uniform, so it doesn't break. Okay, so please keep in mind, if the halos are breaking, the diagnosis will be cataract. Yeah. ठीक है, so halos are written as like this. ठीक है, so halos can be cataract. If the halos break, it is cataract. ठीक है, if not break, then we will learn it as acute congestive glaucoma. I just missed to include that Finchem's test वाला slide, but yes, I think this was also a question. Incipient or immature cataract. Mature cataract में तो कुछ भी नहीं दिखेगा ना. So when it is too much mature or hypermature, तो फिर कैसे आपको halos दिखेंगे, है ना? You will not be able to see the halos. It is only seen in incipient or immature cataract, where some area of the lens is clear. That is the main funda behind it. Yeah, anything. You can answer this. If it is breaking, it is immature cataract, Dr. Light. Yeah. So what was the next question? Cataract treatment for a 3-year-old child. What did they want to ask you? Was it the time of treatment? Or are they going to ask you what is the type of treatment? Type of treatment will be lens aspiration with primary posterior capsulotomy. Padha hua hai? So what was the question? You have to tell me that. NF1 features, I taught you with the mnemonic ocular. Just go back to your LRR session and your rapid revision sessions. Okay, I think one of you were asking me about, okay, yes, Finchem's test, yeah. So accommodative esotropia. Again, this has been dealt in your LRR session. One of you are asking about this. So see, if this is the child with some squint like this, and he is a hypermetrop. So you remember accommodative esotropia kya hoti hai? Because of excessive accommodation, the eye is going inside. So what can be the two causes? One is either hypermetropia or it may be more AC by A ratio. What was the question? Somebody wrote the question. Just let me see if I can. What was the language of the question? One of you have just written, huh? Give me 1 sec. Medicine World, you have written a 9-year-old boy presents with high accommodative convergence to, okay, AC by A ratios का ज़्यादा है, ठीक है, diagnosed when he was 2 years old, as mother would like a second option, she is concerned about. So if there is a high AC by A ratio, right? Well, how can you relax it? Either we go for pilocarpine, because pilocarpine क्या हो रहा है उसमें? Even a little bit of accommodation and there is convergence of the eyes. You want to relax the accommodation. So you give near glasses to the child. And second is we can give pilocarpine. Why? Because pilocarpine will cause meiosis and accommodation. जब आपने बाहर से करा दिया तो central impulse doesn't happen. Therefore, there is no convergence. ये convergence क्यों हो रहा है? Because centrally there is AC by A ratio is high, isn't it? So these are the two main managements. I think if I get the exact question, I will be able to answer that what they were asking. But please remember, accommodative esotropia can be due to refractive, where it is due to high hypermetropia. जो कि इस child में, this is being shown here that if the child is given specs, the hypermetropia is corrected, the child starts looking straight. So that is the best part to happen. No surgery required here. And AC by A ratio, again, we don't encourage surgery. We either go for near glasses or we are going for pilocarpine, right? Or it could be both factors. That is called mixed type of accommodative esotropia. Malik, any other question? I think yes. So that this was all I was given as a recall questions. Anything else you want to ask, you can ask. Acha, surgical options were there, okay. डबल स्प्लिट ग्लास क्या होता है? दैट इज योर एग्जीक्यूटिव बाइफोकल्स ना, बच्चों में वही देते हैं ना. आर यू टॉकिंग अबाउट दैट? ओके, पाइलोकार्पिन वाज नॉट इन द ऑप्शन, बट डबल लेंस ग्लास कैन बी गिवन ना. Okay, so if they are saying that even the glasses are not working, then there is the last option is surgery only. So if it is an esotropia, you want to what will you do? What is the basic of any strabismus surgery? Tell me. So for an underacting vessel, we cut and stitch. That is called resection. For overacting, we just shift the insertion back, which is called recession. Yeah. No, shield ulcer, we will answer spring catarrh only. No, atopic keratoconjunctivitis is another type of allergic conjunctivitis, but shield ulcer specifically, we should answer spring catarrh. Okay, just DM me medicine world. Just give me the whole question. I'm going to come back to you. Yes. So KPs, of course, you all will do very good and you all will pass. And also try to, there is a continuous revision going on in my Telegram channel also. Okay, so you all can be in touch with the questions and of ophthalmology there itself. So keep in touch. Abhi, give yourself some break, take some rest, breathe. Okay, the work is done, right? Be positive, don't panic, just relax, keep smiling, huh? And stay blessed. सब ठीक है? And any confusion in any question, and if you feel something was not answered, you can definitely just DM me. ठीक है? अच्छा. That means the number of questions were even more than these, huh? 17, 18 से भी ज़्यादा. Okay. Yes, blunt trauma का question में तो rosette shape cataract, there is no confusion. No, you will always answer rosette shape. Oh, Dr. Light, it's okay. You know what? Sometimes crying is a very, very think, "Arey, you were crying," or you know, only brave and simple people can cry. So never be ashamed that I was crying on them. They are your purest waters. You know? So it's absolutely fine. Only courageous people and people who are simple they don't hesitate in crying, and it's absolutely fine to be sensitive. Let's be very hopeful, right? And let's be very positive. Don't worry at all. And I'm very happy now you feel, Dr. Light, that Avta was simple. Yes, it was simple. Okay? Don't worry. ट्रैकोमा स्वाति किस चीज का आंसर आप बोलना चाहते हो? सेकंड क्वेश्चन में ट्रैकोमा आप कह रहे हो, एक मिनट रुको. व्हाट वाज द सेकंड क्वेश्चन? आई लॉस्ट ऑल द व्हाट हैव, सॉरी फॉर द स्क्रॉल, बट इसमें ना, या cataract and blunt trauma was first, second. So shield ulcer typically is for, there is no confusion here, it's spring catarrh. Where do you see shield ulcer in trachoma? Trachoma में terms क्या याद किया था? Arts line, Herbert pits, Herbert follicles. Do you remember? It's very simple. Don't confuse yourself. See, Nilu, if there is a malignant glaucoma, we are saying Aqueous is going into the vitreous. There is no question that anterior chamber will not be shallow. Then there is some problem with the framing of the question. Then I won't accept it as. समझा? ऐसा नहीं होता है. No more crying and getting upset. We all will be very happy and positive. This is what we have in our hand, to be happy, positive, and just relax and enjoy yourselves. Too much of studying has been done. We will again start. थोड़ा reboot करो. ठीक है? क्या गम है जिसको छुपा रहे हो? हाँ, वो वाला हाल था. Yes, it is a cakewalk. We always enjoy studying ophthalmology together, isn't it? So what did I tell you all? If you see a part 1 and part 2 in ophthalm lecture, please don't only listen to part 1. So last time in your LRR, there was some technical issue, which is absolutely, see today I would start a little late because of confusion of the key. So you have to understand that ये तो होगा, कोई बात नहीं. Let's take it more sportingly, isn't it? So please always see both the parts of the lecture so that you cover the whole course. Majority of the questions were covered. If you had studied it properly, na, to usme 90, more than 95%, 96% questions to discuss there, isn't it? VKC is the option for shield. There is no confusion at all. There is no confusion in my mind for that question. Okay, ultraclan, if these are the three options, that what is correct for malignant glaucoma? Anterior chamber is normal. No, it is not. Anterior chamber is very, very shallow. Pilocarpine definitely will not be given. Aqueous cannot move to anterior chamber. That is a correct option. है ना? JJJ, ये तुम्हारा नाम बड़ा इंटरेस्टिंग है. जिमी जयपुर जैक्सन. ऐसा कैसा नाम? हाँ, you all are very creative in this one. God bless you. No, needle holding is not like this. Tushar, have a look at what is a needle holder. Okay? Yeah, I'm still waiting unless and until you all say, yes, ma'am, it's done. No more questions? Okay, so I'm ending the session. All of you, what did I say? Be positive, keep smiling, and stay blessed. Right? Thank you so much.